for joining us this morning. We have been having a series of conversations around health disparities, and today I'm really excited to be joined by and this not only from a national perspective, but more importantly from a community health perspective. And so on today, what I'd really like to do is just get some context around where we are from a disparities standpoint. When we first started this series on health disparities and looking at various perspectives, we started, and it was mostly around COVID-19, right? And it was around just the gross disparities that we were seeing with regards to the outcomes with COVID-19. And we have been, from every state to what we're doing federally, everybody's really been trying to get their arms around how to manage, monitor, and move forward, right? Given this unforeseen circumstance and just the reality of this pandemic for all of us. And then in the midst of that, we have seen where racism has reared its ugly head again. And so, I want to also are very much connected to all of the isms, I'll call it, and discrimination, right? Being one of those, or racism, if you will, being one of those. And so we definitely want to bring some context to that. So let me start off. I want you guys to do a little bit of introduction. I am pleased to have Adam Thompson with me. Adam and I are colleagues. I'm going to let Adam talk a little bit about himself momentarily. Ace Robinson. Mr. Robinson comes from an infectious disease standpoint, and he has tons to offer us. And then Dottie Dowdell, Dottie, her expertise in training and education, which we know that is fundamentally important when we start talking about community. And I may even throw in a little bit of research that we did, Dottie, just to kind of get some pointers from you, because what I've learned personally is how community education in a meaningful way really drives huge impact in terms of eliminating disparity. So let me start with you, Dottie. Why don't you introduce yourself? Tell us a little bit about your work.
Thank you so much. Good day, everybody. My name is Dottie Dowdell, and I am the Chief Executive Officer for Creative Training and Development. And what I do is I train and I develop curriculum. I also teach at Rutgers University. I teach in the School of Social Work. I teach the social work perspective on HIV and AIDS, as well as diversity and oppression. I'm also, I'm a full-time independent consultant. So I do a lot of work in HIV and disparities and education. So and I also have some history in child welfare. So I also spent 12 years in the New Jersey Child Welfare Training Academy, focusing on curriculum and training and professional development.
Awesome. So, Mr. Robinson, tell us a little bit about your background.
Hi, my name is Ace Robinson. I'm the Director of Strategic Partnerships and the Center in the Epidemics at NMAC, as formerly known as the National Minority AIDS Council. And my real focus in the work that I do is really on how are we going to address health disparities as they apply to racial, ethnic, gender, and sexual minorities, including people who are transitionally housed or have experienced homelessness, or people who maybe currently or past have utilized illicit substances. And like my whole goal is how are we going to improve those health outcomes as it relates to communicable diseases, whether it's HIV, sexually transmitted infections, things like viral hepatitis, now of course COVID-19. Because I think as we've seen, We cannot look at healthcare or healthcare outcomes and vacuum. Like your life is going to be a part of all your environment, the people around you, and the opportunities that you have set in front of you based on every aspect of life. And that's the whole piece of things like when we're going to talk about COVID-19. It's like we're not talking about individual acquisition or progression, because COVID-19 doesn't care about your background, but we're talking about that community level. Like how are we going to look at health disparities when it comes to COVID-19 acquisition and progression, and how are we going to address that and respond in an appropriate and equitable manner, not equal manner, but equitable manner. So thank you. I'm glad to join you today.
I'll let you introduce yourself, but let me tee up a question first. So answer the question and kind of, I'm sorry, tell us a little bit about your background and then go directly into answering the question. So when we first started talking about having this particular conversation, it was because there was a comment that Dr. Fauci had made maybe epidemic. And, I remember going through that particular era, meaning when we were looking for, where the disease, and then really trying to into the next phase in terms of, being able to control, if you will, to some degree. And now look where we are. I'm curious to know, or first tell us, the work that you do, but I'm just curious to know your thoughts about, Dr. Fauci's comment and basically looking at what we're seeing with COVID-19 parallel to what we saw with the AIDS epidemic. Your thoughts, Adam?
Great, thank you so much, Knitasha. You were cutting out just a little bit, so I want to make sure that I contextualize the question correctly. You're referring to Dr. Fauci's statements about the underlying conditions that were putting Blacks and African Americans at risk for COVID, correct?
Correct.
Okay, yeah, so first, thank you so much for having me here today. My name is Adam Thompson. I'm the Regional Partner Director for the South Jersey AIDS Education and Training Center. We're part of the federal Ryan White HIV/AIDS program, and in particular, our widget in the shop that I work in is to help Ryan White agencies, so those would be organizations, whether community-based or clinical agencies, who are providing care supportive services to persons living with HIV. I also serve as a coach with the Center for Quality Improvement and Innovation, which is our sort of quality machine inside the Ryan White program as well, and most recently worked on a large campaign around HIV-related health disparities in 4 communities that were experiencing disproportionate outcomes. In fact, I worked very closely with Dottie on our youth affinity group, really looking at interventions that would be effective at pushing the needle for young folks. What we saw there, and I think what sort of breathes through a lot of not only HIV care, but I think healthcare in general, was that the more we were able to tailor those interventions to the people who are actually supposed to benefit from them, the more successful they were. And most of those interventions were cultural in nature. It was about understanding youth. It was about understanding autonomy when you're 15 and everyone's telling you what to do, but your healthcare provider is telling you you make your own decisions. So it was a really interesting environment to sort of play in a quality space. But I think coming from a quality space, in sort of referencing back to Dr. Fauci's comments, I spend most of my job in a quality way helping people make sure they're working on the right problem. I see far too often where people put a lot of effort into solving problems they didn't have, or a problem that was actually a symptom of a different problem. And so when Dr. Fauci spoke and he identified, underlying conditions such as diabetes and heart disease, that these were the underlying, sort of reasons why you were seeing these increases in COVID mortality in communities of color, particularly Black and African Americans. As a quality person, I sit in between public health and clinic. So I understood what he was saying clinically, what the risk was. However, I felt like with a microphone like that and sort of speaking about what is risk and what is happening in our communities, I was really looking for a both and moment from Fauci, where we could talk about how diabetes and cardiovascular disease are, yes, in a clinical way, putting people at increased risk for COVID. But I think what was missing was the and. These conditions like diabetes and cardiovascular disease are the result of systemic racism, anti-Blackness, healthcare that's not respectful to the people that they serve. And I think by not talking about that, it really leads people who are often, a lot of times in the positions that I'm sitting in, white cisgendered men in a public health position, thinking that the problem is diabetes. And while it's very important to focus on diabetes, it's a huge concern for our communities, particularly communities of color, and particularly in the South. However, to not connect that to the underlying reasons that those conditions exist, I think it didn't paint the whole picture, and it leads public health to fight a problem, but not necessarily the right problem.
Yeah, that's an excellent perspective. Based on what Adam just said, Ace, I think we all knew and recognized, that I should say the prevalence of disparities, right? And I guess to some degree, I was quite surprised that the rest of the world was surprised that there were disparities that actually came out of the COVID-19, numbers. And so, just some thoughts from, your background and history and your work in communicable disease. I mean, is there something different about what we've learned outside of the real differences, right, about COVID-19, meaning how it performs, as a disease, so on and so forth. But is there something different about this disparities conversation, I guess is what I'm asking.
Well, when we talk about unmasking the health disparities that pervade our community, so when the conversation started going from the international news to the national news about this novel coronavirus that was being identified in China, we started having conversations that once this is starting to be identified in the US, this was going to be primarily a conversation about Black people. So like before the CDC released the data that showed all the information we know now about this being disproportionately Black and Latinx to a certain extent, we learned, we started having those conversations like we need to prepare the Black community for this because we saw a lot of the conversations around Black people can't get COVID-19. This is just white people and Asians. And then you start having like these conversations of well, as long as you literally start having conversations, as long as you avoid all white spaces or all Asian spaces, COVID-19 will not be a part of your existence. And then if you remember, one of the first people who was clearly Black who came out and said they were living with COVID-19 was Idris Elba. Pretty well-known actor, people pay attention. And if you're not into the acting world, then basketball players, Kevin Durant was coming forward and other basketball players. And then the community conversation really began. So the reasons, like when we look back in time, because I'm all about root causes. I don't want to have this conversation about today because then we're not going to get to tomorrow if we don't know where we actually came from. So we start having these conversations around medical mistrust. So like I was just talking earlier, I was sharing this book earlier, it's called Medical Apartheid. And Medical Apartheid is by Harriet Washington. And she speaks about how we got to the point where we had medical distrust, not just for the pharmaceutical industry. How many conversations are we hearing now about, well, the vaccine comes out, are you going to take it? And is the treatment actually going to help us or are they hurting us? Distrust for the clinicians who are providing our services, and we can talk about Tuskegee or other like the National Public Health Service syphilis experiment in Tuskegee, Alabama, where people just really like we were talking about into the 1970s, into a lot of our lifetimes, that there was complete I don't know, every word you can think of. There is the most abhorrent way that researchers could have a cure for something, but not let Black people know about it. And then we start having all these conversations about, oh, are there cures for this? Are there cures for HIV, but they're not telling Black people? Is there a cure for syphilis? Because, well, we did have one, but they didn't tell Black people till later. Is there a cure for cancer, but everyone knows it but Black people? And so like we start having to really undress these things that were not created by us. We know that racism exists, and Black people, is not our job to fix racism. It was created by white people, so we need, like, the white people have to go into their own house and fix it before we start dealing with it in our own, before we can start undoing it in our own communities, because we need the dominant community to stop putting it upon us. So with all of that background information, like, the most important piece is, how are we going to have culturally responsive and timely healthcare delivered to our community? So when I'm saying that, I'm saying, like, well, we know that we don't have as many Black doctors out there. So, okay, well, if you don't have as many Black doctors, while we're working on that piece, we have what we have. How are we going to make sure our clinicians know how to speak to us in a way that is not demeaning, not disrespectful, and then also is in a way that engenders trust and understanding. And then we start having those conversations of, if we do have treatment as available, making sure that people get it. Because as you see, like, many of us on this conversation are from the HIV field. And like, you look on the national news, why do you see so many people from the HIV field? Because we just take the data and we try to apply it in a sensible way to the communities that are disproportionately impacted. That's not what happened in HIV in the 80s. We saw that a lot of people thought it was about white gay men, just like we thought that COVID-19 was about whites and Asians. It never was about one particular community. It was probably always disproportionately the Black community, but we weren't on the TV speaking about it and getting a lot of attention about it. So now we're at this point now we have this information. What are we going to do about it? And that is where we're really pushing to make sure this information goes out, and why this conversation is so important, because we have to let everybody know that this was never about any other community. This is probably going to be about us for years to come. And the final piece, and then I'll be quiet. So right now, I didn't say where I'm sitting. Right now, I'm sitting in South Georgia, taking care of some family support. But like, I'm in the part of Georgia that made the international news because there are so many people acquiring and dying from COVID-19. I lost multiple family members from COVID-19, and it was all because of that intersection of access to healthcare, access to information. There was some information going out about social distancing and hygiene that is necessary, but that didn't reach Black people in the South until it was too late, and all these people were dying left and right. And then we're talking about a whole system of individuals, like Adam was speaking about. Like, I'm now in this area that has been Walmarted, and everyone knows what Walmarting means. Walmart came in, every other store around it closed down, including grocery stores. You go into the Walmart and you can only find sugary this, sugary that, sugary this, sugary that. Like, for if you want a healthy diet, that is so difficult to get, even if you do have that information. And then if you want culturally competent and responsive healthcare, well, Atlanta's going to be the closest place for you to get that. So do you have 2.5 hours to go to your primary care appointment when you're probably working an hourly job at the local market? So you take all these pieces, and this is where we are today. And COVID-19 has unmasked all of these issues when it comes to how are we going to go from top to bottom of ensuring that we have representation and leadership in healthcare, representation and leadership in government, representation and leadership in all facets of our life.
Yeah, this is really good. I want to unpack that a little bit as I transition to you, Dottie, because I mean, Ace, both you and Adam raised some excellent points, and here's one of the things that came to mind as you guys were speaking. You know, that I am my grandmother, right? So you're talking to a fairly young woman, but my grandmother was raised on a plantation and was a child of sharecroppers, right? And so when we think about, you know, this era, or this, I'll say, barrier of trust or mistrust rather, you know, I think people, for the most part, believe that, you know, we're so far away from, you know, some of the things that you talked about, Ace, in terms of Tuskegee experiment. But the reality of it is those things are still very relevant today. And I also believe that there are still things that has happened where our health systems haven't been as transparent, where our health systems haven't been in partnership with our community, similar to, the statement that you made, Ace. And so that further exacerbates, right? I think the issue. So, Dottie, can you unpack that just a little bit for me in terms of what that means translatable on the ground in terms of the training and education that needs to occur, right? How do we begin to shift what Adam and Ace have talked about, right? Because one of the statements that Adam made is, the way we were able to get our arms around this, we focused on the who, right? We focused on the individual, right? And then we kind of, moved it up the pipeline. So can you help me from a community health perspective? How do we even begin to shift this?
So I think one of the ways to begin to shift all of this is to have the difficult dialogues, and to have that conversation, and also providing education. One thing that I understand about the Black community, at least in my experience, is that Black folks are really not trusting of like we said earlier, about the medical field, right? So when we hear about these particular diseases coming about, there's a bit of apprehension, if you will. Like, okay, like there's some apprehension, there's some, okay, what's happening here? Even when we talk about like care and treatment, it's like, I don't know if that's really going to work for me. You talk about, even when I think about like HIV and how a lot of times in the early days, a lot of people of color didn't want to take medication for fear of not knowing how this medication will work for them. But as it relates to COVID, I just remember hearing conversations from community, like, as Ace said earlier, this is a white or Asian situation. It's really not impacting Black folks. And because of that, folks have been putting themselves at risk, not knowing. So I think these are some things that we need to take into consideration. One is having the conversation, and maybe people of color speaking to people of color that have the information, right, to hopefully bridge that gap.
Bear with me 1 second. Desiree, I don't know if you're able to either mute or disconnect the line, because I'm losing part of what Dottie's saying.
I'm on it. I'm just going through and muting everybody now.
Okay, thank you. So Dottie, if you can just repeat your last statement so that we can bring it home. I apologize.
Yes, no, that's okay. I think what it takes is, it's going to take some level of education, right? Educating the community, having people of color speaking to people of color, having people that communities of color trust, to have that conversation around what's happening, because communities of color are very skeptical of things that in the medical field. We're very skeptical, right? There's conversations I've had to have with my own family members around precautions, and how folks become very like resistant almost to even some of the safety precautions, because they always feel like folks are always trying to tell us what to do, and I just want to live my life. And so I've had to have these conversations in my communities, and also with my family, around precaution, and just helping them to understand that this is really real. And until it starts hitting home, then that's what brings about some level of awareness.
Yeah, so what are some of the barriers? What are some of the things that we're hearing? And I'll give you an example. I've seen, and Adam, I think you and I may have had a conversation about this, but there was an individual that I know personally that basically said, he told people, he said, don't you go and take the COVID test, because if you take the COVID test, all they're going to do is inject you with the actual disease, and now you will show up positive. I heard that from an individual that that I went to high school with. That wasn't something that I kind of heard pass through a couple of times, and he was very convicted, by that as well. I have heard the same thing about influenza. I know you guys influenza, and if you look at the influenza vaccination and even the rate among African Americans, generally speaking, our rates are typically lower in terms of influenza vaccination. And, you know, folks will tell you in a minute, yeah, I'm not taking that because I'm just going to get sick. Why would I go and get sick? There's another person that I saw on Facebook that basically said, did you know that a doctor is able to bill $34,000 for a COVID visit? And he gets paid in whatever that amount was that the person stated. And he said, and so it is in their best interest for you to show up positive for COVID, you know, based on the amount of money that they're making. This is a money-making scheme. I was in a store just last week, and there's a big sign posted on the store as you walk through the door, and it said, no mask, no service. So when I get up to the register, there's a gentleman that comes next to me, and he doesn't have on a mask, and he's ringing the guy up. And I said, isn't there a big sign on the door that says no mask, no service? And the young Black gentleman turned around and looked at me, and he said, but yeah, I work here. And so when I left out of the store, he and I had a conversation outside the store. And I said, brother, I just want to share something with you, because I wouldn't be doing this if it weren't in your best interest. I said, wearing a mask is really to protect you. And so we went further into the conversation. He basically told me, you know, the numbers are skewed. You know what they do in the Black community. And this is a young, and when I say young, he had to be all of maybe 20 years old. And he told me, you know, the numbers are skewed. All they do is, you know, jack the numbers up for our community to make us believe that the issue is, more active in our community. So all of these things are very real. And, and so, how do we, from a systems perspective, begin to get to that more granular piece that Dottie's talking about, Adam? Like, how do we, from up here, how do we now make certain that we're making all of this translatable to folks on the ground so that we actually do better? Well, I mean, what are some of your thoughts?
Yeah, I mean, so I gotta tell you, this has been swimming in my mind for the last 2 weeks. Dottie and I have been on the phone, I'd say about 2 hours every night, thinking through some of this stuff, because this was our challenge, right? We're looking at this, and I kept saying, okay, Dottie, we have been talking about this. I've worked in HIV for 15 years. This is not a new conversation, and yet we keep throwing the same things at the problem, and we keep trying to use these old tools that didn't do it the first time. And I think what's really interesting, however, is that as a systems person, I live, breathe quality improvement. Quality improvement is about the process, not the people. If I have a good process, I can keep bad people from doing bad things, right? I mean, that's sort of the mantra of it. But it's like one of the things we noticed in our conversations was that we've not put, racism and anti-Blackness through the quality machine before, right? We've done diabetes. We've done our fishbone diagram, our driver diagram. I've done the root cause analysis. I've pumped it through a PDSA cycle. I've used all my quality tools. I've measured it. I have set sub measures. I've got step measures underneath my process to make sure that everything is happening. I've been coaching Ryan White Systems, now for over 10 years nationally. I've been in a lot of clinics, a lot of places. Dottie and I together have been teaching across the country on power and privilege. I've not seen people use our system tools to analyze this problem. And I think part of that is the issue. I realized when COVID hit, the recognition I had at the AATC, our job is to help respond to healthcare. And in that moment, we jumped, right? Overnight, we had new webinars about the intersection of COVID and homelessness, the intersection of COVID and behavioral health. We had a pop-up best practice network. We had support groups show up for our staff who were losing their family members. I mean, it was like overnight, we immediately began addressing this, and it was amazing to watch. And I was deeply proud of my colleagues for what they did. But then when we started seeing these other things happening during our pandemic, that were these flags that have been continually raised, right? And the murder of George Floyd, I think, put this into, again, this hyper focus where people acted individually in the systems that I walk in, right? My colleagues were marching, my colleagues were donating money, my colleagues were posting on Facebook, they were doing all of these things, but we had not done it as a system. And I thought, this was our mistake, right? We jumped at a virus that we didn't know how it was going to affect people. We didn't know how it was transmitted. Think of how little we knew about that and immediately addressed it. But we didn't do the same with this. And so I think the translation, when people say it hasn't translated, I worry it's because we haven't tried in these system tools that have been used in our healthcare, because we've never pumped that problem through it because nobody wanted to talk about that problem. Because as Dottie was saying, it's a difficult dialogue that most of the folks that I work around, white, cisgendered folks, have not been educated or skilled in, or have even the ability to understand how not to get offended in a conversation like this so that you can continue to meaningfully talk about something. And I think that, to me, at least this is where, again, Dottie and I are trying to think through this. For me, this is where I wanted to see my organization go, which was to really unpack and understand what should we have always been doing that we weren't? Two, how did this happen that we jumped at this and missed this completely? And what things do need to happen structurally in my house to understand how that got missed that way so that we can address it? But I think it's using the tools that we have, but putting the real problem through it, and not just saying diabetes, but actually putting this through the quality machine and seeing what happens. As Knitasha, you and I both know, at the national level, there is not national measurement around disparities in healthcare. We've asked for it, we've demanded it, we have had measure developers present before us data that tells us they should do this, and then they don't do it, and there's no mechanism that we can force them to do it. And so if you can't use the tools that we normally use to address these problems because they won't let you hit the right problem or use the right data, I'm at a loss as how the system fixes it if I'm not allowed to use my system tools.
Yeah, that's an excellent point with regards to what we already know, right, about health disparities and the tools and strategies, if you will, that we recognize are effective, yet in a circumstance like this, we are not quick to deploy them. And so I think that we do need to rethink some of that. There's one other piece. So there's some research that I was able to do here in Chicago a few years back, and our work was really to close the gap on the disparities in acute stroke and in high-risk communities. And honestly, the education piece was critical. And it wasn't just the education piece, it was how the education was deployed. I think, and I heard that from all of you guys. So what I mean by that is that when we originally started the work, I literally went out into the community and randomly identified people for several focus groups. And through those focus groups, one, ask them what are some of the barriers that they're seeing, hearing, understanding in the community. But then two, who are the trusted partners that you would want to hear from, right? And what I loved about it is that, researchers, we've been talking a whole bunch about, the barbers and the beauticians. And so there's been a lot of work done in that space. But the beauty of the work that we finished or we did was it was expanded outside of that. They said, it's my pastor. They told us it's the educators. It's the teachers of my children, right? That they trust their messages more over than all others. They told us that, the business owners in our community, so the dude down the street that owns the convenience store, the guy that owns the gas station, those are trusted partners in this whole dissemination piece. And so as we worked in the community over a couple of years, we were actually able to see where African-American men actually were showing up earlier for treatment in the event of acute stroke which was a huge positive response, considering where we had started a couple years ago. But I think the critical piece to it was who we activated, right? Who we gave the messages to, who we relied on to get that message out, and how the community really received them in order to advance that forward. Ace, any thoughts about the who in this COVID-19? Any thoughts about, to some of Adam's point, what we should be doing differently in terms of the activation part?
That is the big piece of from what you're saying that I want to respond to, is that the messenger matters. So we already know, whether you look at data or anecdotal stories, that if you're a Black person in the United States and you're lucky enough to have a Black clinician as part of your life, whether it's a nurse practitioner, your doctor, PA, whatnot, that you're going to trust what they say. You're going to trust that they're not going to be harming you, and you're going to trust any treatment that they might prescribe for you to have a better health outcome. So like when I was on my way to South Georgia for this family thing, I was in Atlanta getting my rental car, and I was listening to the conversations behind me, and everyone was talking about COVID-19 because it was Atlanta, and the response to the uprising was happening, but most of the conversation was around COVID-19. And one gentleman was talking about why it was all made up. And his reason that it was all made up was because these are white doctors in Washington, D.C. trying to tell him what to do. Why isn't my doctor telling me this? And so for him, it was all about who was telling him. And we speak to that whole piece of that structural conversation of who is in leadership at the NIH. And we had the Surgeon General say something about COVID-19, but he used every racist trope out there, even though this was a Black man from Indiana. So we need to make sure that it's not just that the person looks like you, but the message is clear and can be received in an appropriate manner. We cannot keep having individuals who are not trusted give the message, because, well, you're just talking to a wall. There's nothing really happening. To give one example from our HIV land, there's some conversation around PrEP and can they get Black people to utilize PrEP? Well, there's a group of researchers who were Black men who developed a trial about Black men. They educated Black men about a trial about the benefits of prevention and treatment. And then surprise, surprise, that not only were the individuals, they stay in the trial, but they actually decided that, oh, I trust this, and they're going to continue using it. And then it got all this international attention. It was all like, oh, how did they engage these? And the term that some people use in the public health field is very demeaning term, hard to reach populations. We have one of our colleagues say, there is no such thing as a hard to reach population just because you don't know how to reach them. And so being very clear that if we're going to reach people and speak about COVID-19, you have to make sure you're utilizing culturally responsive. Culturally responsive just means, are you coming up with an advertising campaign that makes sense? Like whether it's marketing healthcare or marketing Coca-Cola, how are you going to get to the community that is most served? Because I promise you, if I go into middle of nowhere, sub-Saharan Africa, I will see Coca-Cola. How did they do that? They advertised for the people who are sitting in that area. They made it look appealing, and they trusted the product they were putting out, and boom, there it is. But for those people who were utilizing images and sounds and sound bites that don't reflect the community that they're trying to get into, there's no Coca-Cola. I mean, it's simple marketing, and it's something that we have to do when we turn that mirror around. We have to turn that mirror around and say, well, how are we failing on these individuals as to reaching them? Because there's going to be some equivalent white person who doesn't trust the medical field, but they have a lot of influencers telling them, actually, you might be wrong. You need to open your eyes to this information and that information, and this over here is actually incorrect. And so how are we going to make sure we get to that point in our community?
So I want to go to a question that's in the chat. I don't know if you guys have seen it or not. Excuse me, and I think it aligns with some of what you were talking about, Ace. So the question is, how has the community been informed about the Gilead program? And then it goes on to basically say, are the medically underserved getting adequate information in a timely manner? And so I want to pick up on, or Ace, if maybe you can start, and then we can go to Adam. But what are your thoughts with regards to the timing of even our response and getting that to the for spread? And then the other question with regards to, how much do we know about the community actually being informed about programs like Gilead and its, your thoughts?
The short answer is, are medically underserved getting adequate information in a timely manner? The short answer is no. And if the longer answer is that medically underserved means who's in the back of the line, and who has been continuing in the back of the line. So back to that conversation we had before. So what we're doing different, because we have to be focused on solutions. I can complain all day, but I want to focus on solutions. So the solutions that have come up that have been somewhat developed by community and implemented by the government, there's something called Ready, Set, Prep. It's this program by the federal government to make sure that people who don't have any health insurance at all can get access to the drug. The drug is free. And then it all has to be through community health clinics that work on a sliding scale. So like if you have no money at all, these are the clinics you go to for a free service. So you can get those labs that someone spoke to before, that the question also, the person who asked the question also asked, that you making sure you get all those labs so you can get on PrEP. And then for the people who do have a little bit of insurance and have these things called co-pays and premiums and all that, well, we want to make sure that the drug is free for them. And so that's that piece of that education where we have failed, and we're doing that work currently to make sure that the people who are the PrEP navigators at whatever HIV clinic you go to, that not only do they reflect the community, but they have that information, that they know how to make sure that the person knows that PrEP exists, because they're not coming in for a PrEP discount when they don't know it exists, that they can access the drug and then also pay for it, which is 3 parts to the education. If you don't have all 3 of those parts, you're going to have a failed system. Then you have to have that follow-up to make sure that everything that you taught somebody in the last minute is sustainable. And that goes to that whole piece of, if you are the first person in the history of your people being on this continent to have health care, I can't talk to you about take this drug if you don't understand what a premium is, what out of pocket is, and like, those are those types of conversations you have to have to make sure like they're not going home and talking to someone about this. And I think and when it comes to COVID-19, we're working fast and furiously with the researchers are out there trying to make sure that there is a vaccine or treatment that is really good and that will work. But then it doesn't matter if you build it, they're not going to come if they don't trust you. So right. Are you engaging Black people, Latinx people, people who are disproportionately impacted in the research portion of it? And then are you focusing any attention about how that treatment is disseminated in those communities? Because, just something as simple as getting tested, like you were speaking about, your elder or your neighbor was talking about not trusting COVID-19 testing. I am the number of people who have asked me where to get a COVID-19 test far outweigh that, and they don't know. But I have to do the research to find it in their predominantly Black county. But I've yet to with what I do have some white colleagues, and none of my white colleagues have white patients who don't know where to get their COVID-19 test. Not none, but it's just at a much lower amount. Like the white community has done a great job of letting people know where to get tested and what to expect when you get tested. The Black community, even if you do know where you get tested, people don't know what's going to happen, how far the swab is going up your nose, and and all those types of things, just to make sure people understand what's about to happen and that there's no harm, no foul. You're going to start crying a little bit, but then 2 days later, you're going to have your result and you can move forward.
Yeah. Dr. ask you to pick up, just your thoughts with regards to, because one point that Ace raised that I thought was excellent was, just the different layers of this educational piece that we really need to be focused on in order to drive that level of impact. Your thoughts with regards to that?
I think it goes back to what we stated earlier about just making sure that the folks that are providing the education is trusted by the community. And I like what Adam had just stated in terms of oftentimes the folks that the community trusts, the system doesn't trust to provide that education. So I think that's something that we need to make sure that we're having conversations about. Because you think about, where do we get most of our information, right? Like, think about, whether it's the barbershops, the nail salons, the neighbors next door, the pastors, the imams, whomever that we're connected to. These are the people that we're getting the information from. I'm thinking about early days of HIV when we had to do like prevention, education and prevention, and how we would do like the kitchen sink model and how we would educate the community on how to educate the community, right? So it looked very different, but it worked for the community. And so we have to begin to do education, provide education in the community, but also the systems need to be educated also, because how they may package education and information may not be received by the community. So I think that's something that we need to take into consideration.
I love that comment, that so the people that the community trusts, the system doesn't trust, because we know it's the other way around in terms of the community not trusting the system. But I love the way you postured that, because that is so true. So to the point that we were talking about earlier, and Asa, I was going back and forth. It's like, okay, so the people that the community told us that they wanted to hear from was not traditionally, aside from, like I said, the barbers and the beauticians, because the researchers have been talking about those folks, for a number of years now, right? But for all of these other groups, right, that the community said, this is who we want to hear from, right? This is who we trust getting our messaging from. You're absolutely correct. Those were not the first wave of people that the system would say, now go to these people and let's empower them to get the message out. Or better yet, we trust them to get the right message out, right? We trust them to be effective, with the information. What I found, or what we found in our own research, was when we provided that adequate information. And when I say adequate, we did not go through, give people some quick flashcards. We went into a deep dive education on acute stroke from a clinical perspective. We went into a very deep dive of how our system operates, right? How our system responds to things. We went into that from a legislative standpoint, from a policy standpoint. We went into it from an operations standpoint. People had multiple days of going in, of being educated in this cohort, if you will. And the value of it was so meaningful that we are now 3 years past that research, and there's probably not a quarter of a year that goes by that I don't get a phone call from somebody who was attached to that, who says how critically important it was, and oh, by the way, here's what I did with it, right? That's how powerful it was. But it was because we didn't do the very high level, lacking content, quick messaging to get people out. We really gave them some value and even shifted their understanding, right? Adam, any thoughts about this systems issue and just trust and some of what Dottie had to say?
Yeah, I would just add on, I would agree with everything that was said. And, my first job in public health was an outreach worker for injection drug users, right? I was a homeless sex worker who did a lot of drugs. And so when I came into the system, the boss that I had said, hey, go connect back to the people you know, right? And so when I started reaching out to my community networks, what I recognized was I was very comfortable working with drug dealers, because those were the people drug users were seeing and trusting. And my system did not like that so much, that I was out there talking to heroin dealers. But to me, it seemed exactly where I needed to go. And At the time, I think it made our program better. I think I reached people in my community that would not have otherwise been reached. But I think what we've also seen, and I think this speaks a little bit to the PrEP challenges that we have right now, is that outreach system, those AIDS service organizations and HIV service organizations have been dismantled for the most part across the country, and either had to turn into clinics or begin serving bigger than they previously had in order to survive. But all of the outreach became clinical outreach. We funded now people to go find people that we know have HIV who are either lost to care or never linked to care, and then bring people in. But what's happened is now these outreach workers who were primarily focused in community, not on people living with HIV, but on the identification of people living with HIV, testing in the community, reducing risk, that whole network is in a lot of places gone right now. And I think in this COVID crisis that we had, one of the realizations that I had was, this is what happens when you dismantle the community-based organizations, that when you need these institutions who are, for the most part, much more reflective often of the communities they serve, those messages become really critical. The CDC says in their crisis and emergency risk communication for organizations to be first, be truthful, and dispel myths. Those CBOs were the first ones to hear the myths, to understand it, because they were the closest to the community, but there weren't enough of them to push that out. And so I think when we look at why are we facing some of these problems, I think the CDC's lack of continued investment in outreach and the other institutions not understanding that, but also when they do have outreach, it's considered low tier healthcare and not often integrated into a care team, not paid equitably. You often maybe get part-time, you don't get benefits, and you're watched like a hawk because you're community in the system. And so I think that to me is a huge problem. But I think it's something that people on HIV have been screaming about for a long time, about not letting these organizations go this way. And Knitasha, we've seen this even at the NQF level. There's an incredible medicalizing of our CBOs that's taking place. They're trying to medicalize our peer workers, our community health workers. They're trying to make people who we value because they don't sound like them, sound like them. And I think for the system, it's a giant concern I have, which is how do we respect CBOs for what they do that clinics cannot, and leverage those relationships and partner in a way that funds the CBO so that if the clinic's getting reimbursed for a service and an outcome, that if that CBO is the one that got you the transportation, supported you with the food, and provided emotional support when your family was suffering all around you, those are the people that need to be trusted, and those are the people that need to be valued in the system.
Yeah, I love that comment, Adam, and we got to move that one forward, striking that nice balance, right? Because that is, so my reference earlier with regards to what we did with those researchers, it was striking that balance. It was, I'm not taking you away from the authenticity of who you are, right? And your connection to the community. So if your connection to the community is with, the gangbangers, that's your connection to the community. If your connection to the community, are with active drug users, then that's your connection to the community. And how can we allow you to be authentic in that space, yet still provide you that meaningful information that you can now move and share and disseminate, in the community that reach some value back. So I love that, striking that balance, because that is exactly what we're seeing now. We're seeing where, we want to take people and basically ask them to remove that hat, right? And replace it with this medicalized hat, right? So now they're talking like the researchers, and it's like, no, that's really not what we want. So I love that, and we do have to focus on that. Let me give you guys a thought. I don't see any more questions in the chat. So if there's anyone that's on the line that has a question, feel free to put it in the chat, or unmute your phone, raise your hand, and you are more than welcome to share in this next few minutes of the dialogue. But I'm going to give you guys a question as we make our transition. A national equity goal. Who did I start? Adam and I started off about that, right? There's just been, some conversations around national equity goal. we definitely haven't gotten there. Now we're at this new place where there's a lot of conversation around systemic racism, institutional racism, recognizing that that doesn't just live in the criminal justice system, but that also lives in healthcare. And it also is connected to some of the things that we've talked about on today's call. I'm a firm believer that we need to move forward with a national health equity agenda. And what I mean by that is that we have set national goals around improving quality. We're gonna, reduce readmissions by 15%. We're gonna reduce sepsis by 20%. And I'm a firm believer that we do have all the tools and measures, Adam, that we need to begin measuring the elimination of disparities or the reduction of disparities. But what we haven't had is a very focused effort on that. And then I'm going to say this and ask you guys to pick up. And just looking at social determinants, by the way, ain't going to cut it. Okay, so social determinants are important, don't get me wrong, but social determinants are not the beginning and the end of our quest to really eliminate disparities. And that's because social determinants are measured at the individual level, and it doesn't get us to measuring at the systems level. And if we're going to do this right, we need to have the perfect marriage between the two. We need to be able to do what's necessary on the ground, measure that, but we also need to be looking from a systems perspective. So really quickly, we got 3 minutes. Anybody want to respond to that? National equity goal?
I'm happy to. So there are some good examples out there because, you don't want to reinvent the wheel. And we don't need to always look at the typical healthcare progressive places like California and New York. And the great state of Louisiana, they have expanded their health equity office that is really focused on looking at the disparities from across the board, whether it's gender-based, sexuality-based, race-based, and then giving that person the teeth, because okay, great, I have this information, now what? And giving that division the teeth to amend the practices within social services. So whether you're talking about access to food, access to housing, the things that the government is responsible for, they actually have the power to go in and work with their departments to amend their practices. Because there's things that can be done that we are paying for, our taxes. I think it's appropriate to demand that our taxes are used in a way that's going to benefit the people who they're taking taxes from. Not necessarily who they're getting the most amount of money from if you're from a state that actually taxes the rich. So it's very few of those, side note. But so it's not just supposed to benefit those individuals. We have to make sure that the person who's making $14,000 a year, that their resources are going to be increased, and looking at what are their challenges and barriers. So once again, solutions. Does that mean you're going to have if we're talking about healthcare, that clinics are going to be open into the evening hours and on weekends? Banker hours don't work if you have a 9 to 5 and you're hourly and you have to go get your kid from daycare. Are you going to make sure that the person who's giving you your education is getting into the schools and the community centers and into the nursing homes? Because whether we're talking about COVID-19 or syphilis, they're both in the nursing homes. So we need to make sure that they're getting the information in a way that is culturally responsive. And then how are we going to make sure all of that is going to be sustained, and how you're going to give feedback to the community, this is going well, because #TrustBlackWomen, the mayors of Baton Rouge and New Orleans, so they came together and said, okay, we're going to respond to HIV this way. That's going to come from a health equity lens, and we're going to we want to turn this epidemic around. When once upon a time, Louisiana was the way we talk about Florida now, and parts of Georgia around HIV, we used to talk about Louisiana like that. But they had the appropriate leadership that said, we're going to focus on health equity. And after our focus on health equity, we're going to look at our responses. We're going to measure them. Oh my gosh, surprise, surprise. You give some people support, they do better.
Yeah, excellent point. So I want to thank you all for joining me on today. This has been an excellent conversation. I think that just listening to you all and wrapping up, there are definitely some things, some key points that are takeaways that we know we can do better moving forward, getting information to the community quicker, making certain that we're activating, the right people, and not only activating the right people, but the way in which we activate, the right people. And so I really appreciate everybody's time today. I want to thank you again for joining our Health Disparities series, and you all have an awesome day. Thank you.
Thank you.
Thank you.